Hi, welcome to Iron's Health Talk with Dr. Akram. I'm Akram. In this program, we'll be talking about all kind of different health issues with different experts in the field. Today, we'll be talking about knee replacement surgery. So sit back, relax, and enjoy your time with us. Knee replacement surgery is a common operation that involves replacing damaged, worn, or diseased knee with an artificial joint. Adults of any age can be considered for a knee replacement, although most are carried out on people between the ages of 60 and 80. Knee replacement, also known as knee arthroplasty, is a surgical procedure to replace the weight-bearing surface of the knee joint to relieve pain and disability. It is most commonly performed for osteoarthritis and also for other knee diseases such as rheumatoid arthritis and psoriatic arthritis. In patients with severe deformity from advanced rheumatoid arthritis, trauma, or long-standing osteoarthritis, the surgery may be more complicated and carry higher risk. With 718,000 hospitalizations, knee arthroplasty accounted for 4.6% of all United States operating room procedures in 2011, making it one of the most common procedures performed during hospital stays. There are over 100,000 knee replacement surgeries performed in the UK hospitals every year, and it's becoming an increasingly common procedure, and the number of surgeries are rising annually. By 2035, the demand for primary total knee arthroplasty is projected to increase to 1.2 million surgeries performed annually in the UK. A large part of the predicted demand is a result of increasingly aging population. By 2030, it's forecast there will be around 15 million people in the UK over the age of 65. Let's look at the history a bit. The was performed in 1968. Since then, improvement in surgical materials and techniques have greatly increased its effectiveness. But the development of total knee arthroplasty began back in 1860 when German surgeon Themistocles Gluck surgically implanted the first primitive hinge joint made of ivory. Okay, for the time being, let's look at what is this knee replacement surgery is about, why is it important to us, what kind of healthy lifestyle would keep us away from the surgeon, and after all, if we end up having one, what do we expect from the new knee? Let's welcome our special guest, Mr. Jehangir Mahaluxmivala, who is a senior consultant orthopedic surgeon in Harlow, Essex. Hi Jay, welcome to our show.
Thank you very much.
How is your day today?
Very good. Thank you so much, and thank you for the invitation.
It's very interesting. I think it's a quite interesting topic we're going to talk about, knee replacement surgery. A lot of people would have heard about it,
Of course.
but I think the practicality and all these things, we're going to explain in more detail about it. Okay, first of all, can you explain a little bit about you? What made you an orthopedic surgeon? How come, what is your life about?
Thank you, Akram. Like I said, thank you so much for the invitation. And I'm a consultant orthopedic surgeon at the Princess Alexandra Hospital in Harlow, which is between Hertfordshire and Essex. And my private hospital is the Rivers Ramsay Hospital, also in Hertfordshire, but serving the population of Hertfordshire, Essex, and North London. Now, just for the public, I'm a consultant orthopedic surgeon, and as you know, Akram, orthopedic surgeons are surgeons who look after joints, bones, and fractures. But I'm fortunate enough that my subspecialty interest is what I exclusively do, or 95% of my work would be knee problems and hip problems and knee and hip surgery. And I personally have a passion for knee replacement surgery. I trained at the Royal National Orthopaedic Hospital in Stanmore in London, and then I took time visiting centers where they did a large volume of knee and hip replacement, like you're saying, in North America. And even though I pride myself of saying we can take on, like you showed, the complex surgery, the risky surgery, I think it's important that from the patient's perception, they have to get a best outcome. And that's important to know when we also cannot offer them surgery. And that's very important, Akram, that we spend time with patients in a consultation, which I like to do. At the same time, educating the public about when knee replacements or when surgery can help and not help. And therefore, shows like this are excellent. And I'm very happy to take whatever questions you want or the audience wants.
How common is knee surgery?
Knee surgery, if you talk about knee replacement surgery, Akram, you were very right.
Yeah.
You've shown the figures. They are massive figures. Okay, 100,000 in the UK, and that's going to increase. In the US, it's even higher, and that's an aging population. And also, it's a very good patient satisfaction procedure. So one of the questions you'd asked is why, about doing orthopedic surgery is that knee replacement and hip replacement, but knee replacements have very good patient satisfaction outcomes among all surgeries. So it's very gratifying to do. And therefore, it's common to do. But at the same time, like I said, we have to do it for the right reasons, Akram. Mm-hmm. So that's where we are.
Yeah. What kind of conditions leading to this knee surgery or
I think we have to be, thank you. I think we have to be very clear that knee replacements are done, and the word which the public should understand is done for severe or significant, whatever word you want to use, is arthritis of the knee joint. And the way I explain to patients is this arthritis is commonly due to wear and tear, or you can call it old age. I don't like to say that. It's wear and tear, where the joint surface have got damaged, and therefore we do it, okay? That's one. We do it in a condition you touched upon called rheumatoid arthritis, and just for the public, it's a condition which affects many joints.
Yeah.
But even that, I'm very particular. The mainstay of treatment when you have pain of rheumatoid arthritis in many joints is not a knee replacement, it's medical management.
Medical management, isn't it?
Correct.
Okay, we're going to go for that. And before that, I'm going to pass a message. This is a live program, so call us on 0203 515 5788 if you have any questions or suggestions, or write to us healthtalk@intv.co.uk. And you can also follow us on Twitter and Facebook, Iron Health Talk with Dr. Akram. And of course, you can watch us on Facebook Live, intv.co.uk. Okay, let's go back to the subject. Okay, let's talk. We had a program, a full program on arthritis, and
Sure.
we have covered in general what is arthritis about. Would you like to say a little bit about arthritis of the knee?
So I like to divide arthritis in the knee into two big groups, or let's make it three big groups. The first group is the classical patient who's very clear that I'm most likely middle-aged or becoming older, that they start getting significant pain in that one knee joint. So it'd be the left knee or the right knee, and there's no real injury in the past, so they start, and that's due to wear and tear. So that's one group.
One group, yeah.
And when that group becomes more severe from the pain, etc., which we'll touch on later as to when exactly I offer to the public a knee replacement, because that's important to know, and we can discuss that later. So that's one group of arthritis, okay? And that's called osteoarthritis, which is involving one large joint like the hip or the knee. The second group is the group which, like we said, got rheumatoid arthritis, which unfortunately it's not my speciality, because that's looked after by the medical consultants, the rheumatologists.
Okay.
And they treat the patient for patients who have rheumatoid arthritis, who have pain in many joints and swelling in many joints. And then when one knee becomes very painful, at the end of all the medical management they've done, and the x-rays show the bone grinding like we'll discuss later, that's the time when I will come in to do my knee replacement surgery.
So the first help for these people they go through the GP and the normal cycle, isn't it?
Correct.
So if they have knee pain, they should go to GP.
It has to happen, yes.
Okay, they don't come to you straightforward into your hospital or private clinic and I want a knee replacement.
Exactly.
No, it doesn't happen like that.
Thank you for saying that, and that's, Akram, it's very correct, because knee replacements are so popular, Akram, like you've said, it's a patient's perception that, oh, my friends had it, my cousin, everybody wants it done, and they come, and we have to be very clear. And because I'm so specialized and I only see patients who, when they come to me, they'll be ready for a knee replacement. Yeah. So they first, go to their GP, and the GP will treat them with things you may have discussed in your previous arthritis program, where they will try things like, if they have if they can do weight loss, that helps.
Weight
but we'll
loss,
come
yeah.
to that. If they want to do things like exercise and physiotherapy,
Exercise, yeah, we
that
talked
helps.
about exercise, yeah.
I
And
think
we talked about exercise, and actually my guest Fariduddin, he said there was a study in Bournemouth where the professor was doing it, and he had divided them into two groups, and one group, and he asked them to go cycle for 6 months, like maybe static cycle or whatever cycle, and the other group kept it random, so they just had normal life. And those people who had cycled for half an hour every day, they had 60 or 70% less chance of having that knee replacement. The knee has recovered, yeah.
Good point. And I would say, I was just coming to that among all the exercises, and like I said, I don't treat this group because they come to me when they are ready.
Exactly.
But generally speaking, I would say that cycling is very good, and that's the public needs to know, that I would really say cycling, adjusting the seat and doing cycling is very good for knees. It's good because what I try to tell patients is by keeping your muscles and being strong, it doesn't mean the pain is going to go away. But when the time comes to do your knee replacement for the right reason, which I'll talk about later, then you are going to have it's better for you.
Better for
there's
you,
no
exactly,
So that's one. So exercise is what they would do. And generally, I feel that they need an x-ray at the bare minimum very early on. And most GPs would do that, but that's what I would advise, that you need a plain x-ray quite early on to see where you are in your arthritic process.
Okay.
And that's something which I feel should happen reasonably early, so then the patient knows where they are in their arthritis.
In the arthritis process. Okay.
Process, exactly.
Yeah. Okay, let's have
so the GP does that first.
Okay, so the GP. So let's say that patient had pain and he has reached the GP.
Yeah.
Now the GP has ordered an X-ray.
Yeah.
So let's look at a normal X-ray, and we can explain what is a normal X-ray.
Sure.
Then we go back to an X-ray.
Yeah. Okay. So that's, if for the public who can see it on the screen, that's a knee replacement. There's a knee, and on the top is your thigh bone, on the top, which is called the femur. The lower end is called the tibia. And for everyone to know, there's a gap between the two bones, okay? And that gap is equal on both sides if you make out. And that is something which is good. It means your knee, and for the public, is not grinding away. So I like to see an X-ray like this, where the bones are not grinding. Now this is very important, Akram, is that unfortunately there's a group of patients, and we'll come to that later,
Exactly, yeah.
whose X-rays may look like this, which in brackets is not bad at all, it's like nearly normal, but they themselves are saying, oh doctor, I'm in a lot of pain. These are the ones which I find among all my treatments, all my complex, these are the ones who are very difficult to treat, because I can't offer them joint replacement surgery, I'll come to, but we still have to look after them.
Yeah.
But I'm glad you put up this X-ray, because this shows what is a normal X-ray.
Okay, I'm going to hold you there. There's a caller there. Let's get a caller on the line. Hello, sir. Hello.
Hello, Assalamu alaikum.
Hello, walaikum assalam. Sorry, madam. Thank you for calling us. What's your name, please?
My name is Jehangir Rahman. I'm Bengali.
Okay, go ahead, please.
You Bengali?
I don't speak Bengali. If you could tell us in English, we can translate. Unfortunately, my team, we have a team inside in the control room who speak Bengali. I think the guys just walked out, and I have a few guys, I don't think they speak Bengali.
Okay. I got just a little bit English. No, good.
No problem.
Okay.
Okay, thank you for calling us. Anyway, okay, let's go back and let's look at another X-ray, shall we?
Yeah,
look at an abnormal X-ray with an osteoarthritis,
Sure.
and let's see how it looked like. Here we go.
Okay, so that's the X-ray, and I think everyone, you don't have to be a doctor, but many of you all in the public would be mechanically minded. Okay, so mechanically minded, and you can clearly make out that, see how that gap, which was between the thigh bone on the top and the leg bone below, you can make out it's completely obliterated. So there's no gap. The bones are grinding, and it's no longer straight. So this person, unfortunately, will have a bend in his knee. Each time he puts his weight on it, you can understand that he'll be in pain because the bones are grinding. And you can imagine that with this degree of what we call severe arthritis, even his range of movement will be very restricted, Akram. So this is what is called severe arthritis, and I'm
Severe
sure, Akram,
arthritis.
you can make
Okay,
out.
let's make a comparison of
Yeah.
two different X-rays, two different pictures at the same time. So this probably will be easier to understand, isn't it?
Sure. So thank you, Akram. So this is exactly just clarifying what we've shown in the previous two X-rays. On the left would be the normal space, and that's what Akram has shown is a normal space. And these are the ones where, please understand, even if you're in a lot of pain, it's not something which me or any knee surgeon should say, oh, let me do a knee replacements. And these are the ones where we get not good results because we are doing it for the wrong reasons.
Wrong reason.
Exactly, and that's
So
what
if
I
the
want the
X-ray
public
is
to understand.
if X-ray is normal, the patient still has pain. You do a knee replacement surgery, it doesn't work.
They will not work, and that's exactly why I am very passionate, like I said,
Yeah.
of taking time with my patients. I explain to them that I know you have pain. Let's do other things, but I'm telling you very clearly, I'm not going to replace your knee with an X-ray like that, and no one should. And if you do that, that's one of the reasons why, Akram, in this huge explosion of knee replacement
Surgeries.
a lot of surgeries may have been done when X-rays or the patient is not completely ready for a knee
Ready
replacement.
for a knee replacement.
And that's why sometimes we may be getting a few results which are not satisfying for me as a surgeon
Yeah.
or the patient, and that's because of patient selection. So I hope I've made that clear to you and the
Yeah,
audience.
that's a good point. And since we came there, I was thinking like when you get a patient referred, sometimes you might send them back and ask them to do exercise or change lifestyle, things like that for some time,
Yeah.
and ask them to come back. Do you do this very
I
frequently?
do that a
or-
lot, and I do that a lot because if, let's imagine, Akram, that was second X-rays we shown, which were the very
Yeah.
bad X-rays, and that person is telling me very clearly, and if you don't mind, I'll just explain as to now when to we definitely do a knee replacement, because
Yeah.
that may make it easier to explain when I don't do a knee replacement.
Exactly. Yeah.
So I definitely would do a knee replacement or offer the patient is if that same X-ray which we showed,
Yeah.
right, which is severe. So even your audience who make out that is completely grinding. So that's one
true. Yeah.
criteria.
Yeah.
The patient tells me, doctor, I've tried everything. It's been going on for a long time, and I've got severe pain at night and a limited walking distance of 10 minutes. So these are the ones where I would offer them or consider them for knee replacement surgery. So my criteria is very clear. Significant night pain, limited walking distance about 10 minutes, and X-rays looking like that, and you're a good candidate to get a good result. So that's where we are with that.
Okay. I'm getting the answer. Our caller has talked to the studio, and what was her problem was that she has had some pain under her breast, and she has gone to the GP or she has gone to some few doctors, and she didn't get proper answer, but she still has the pain. But I think it's quite difficult for us to answer this question because that will lead us to ask more questions, isn't it?
Yeah, but this is below where? Where's the pain?
Is under her breast,
Yeah,
probably.
it's something difficult for me to answer. It's not my specialty. It's not
Exactly.
coming truly on the knee. But
Yeah.
I think the caller, the question is that patients who have pain like that,
Yeah.
who are patients who, when you say below the breast, it could be lower down, it could be in the hip, knee, all
Exactly,
that.
yeah.
These are the ones where the first port, I know it's very difficult for her to have gone to GP and got an answer.
Yeah.
But it's very difficult for me to judge as a knee surgeon to give an answer as to what can be done.
Excellent.
But
Yeah.
as a general rule, if the pain is not truly, and you can tell the lady or the lady can understand, if it's not truly in the knee
Yeah.
only, then it's once again very difficult to treat, and we shouldn't be treating with a knee replacement. It's not that I can't treat you with something else, it's not that I can't speak to the patient, it's not
Yeah.
that I can't examine the patient thoroughly, it's not that I can't counsel the patient on what to do,
Yeah.
but from what she's saying, it's definitely not a candidate for a knee replacement.
Knee replacement.
Yeah.
But of course, I think if she has problem, it can be a referred pain as well from a
Very
different
correct.
joint
Different
to anything.
joints, and
I think the best option is if she has continuous pain, she should probably go and talk to the GP and get some few X-rays and make sure things are right.
And the pain is not coming from another source.
From
and
another
I think
source.
the ladies understand, and that's what I also do.
Yeah.
Is even though I'm a surgeon, Akram, like I said, I like to see patients for opinions, and then you have to spend time and give them that opinion.
Exactly. Yeah, that's right.
Because they are suffering, and you need to give them that answer. From what they understand.
Yeah. So of course, the pain is not only the bone pain. It can be from internal abdominal organs. So, so we never know. It's the best thing is to investigate and just make it clear, isn't it?
Sure.
Yeah.
And that's something which you can do from someone else. But when it comes to the joints for hip and knee, they are very related.
Oh, is this medical treatment possible for those who suffer from like kind of debilitating arthritis? Let's look at this small picture. We see what we're talking about, and when you decide surgery for those people.
Sure. So basically, patients whose so that's the picture there.
Yeah.
So if you look at this person, if you look at his legs, Akram, from his knee downwards. So for most people, when they look at legs, they just look at the whole legs. But if you look at his knee, you'll all agree it's very bow-legged. He's bow-legged, and he's walking on a bent knee. And this is because the arthritis is so severe that the joint, which I showed you, has got so destroyed he's become bent. Okay. Now this person, we can't tell him, oh, you go cycling and go on doing it. He can. But if the same patient, and with the same x-rays has night pain, like I says, and limited walking distance, he's a correct candidate for knee replacement.
Let me get this caller online. Hello?
Can I speak Bengali or English?
If you talk in English, that'll be great, sir. What's your name, first of all?
My name is Abdul.
Abdul, thank you very much for calling us. Okay, go ahead, please.
Regarding about my issue, I have recently a problem with the sleeping. When I go bed, I normally used to sleep 6-7 hours, sometimes 8 hours. Now I realize 4 hours or 5 hours.
Is that Abdul? If you don't mind, can I ask you? Are you sleeping less because of pain in your left or your right knee which wakes you up, or generally?
Oh no, doesn't have any pain.
No pain. Okay. So this is something which, once again, that could be looked at for other causes. It is not due to your arthritis in knees being that, but it's a very, many patients, when I tell them about this night pain or night issues of sleeping, we have to be very clear, Abdul, that it has to be coming from pain in the knee waking you up rather than other causes. So it's a good question, but it's I'm interested, or I can offer something if the sleep is disturbed due to the knee pain.
Due to the knee pain.
Yeah, not just not sleeping.
Exactly.
And it's a good question, Abdul, and thank you for that.
Abdul, thank you.
What is the knee pain?
Knee pain is the pain in the knee area. In the knee area.
Yeah.
Is pain or agony in the knee area.
Thank you very much for...
I didn't realize anything. It's just pain.
Yeah.
Okay. Thank you.
Thank you, Abdul. Thank you.
Thank you.
Okay, let's play a quick video, and we're going to show what we do in theatre.
Yeah. Sure.
Exactly, for these people who's got these knee problems.
Sure.
Let's play with the volume so we could hear it as well.
Should I go through?
Oh yeah, you could explain about it.
Yeah.
What is it about?
So just that's a video which I had made for patients to understand. And look, see what's happening to the knee. It's showing the arthritis. See how irregular the smooth cartilage has become, and see how the bone is grinding. So that's when you have got your severe arthritis. So what I do is, when I've decided that you need a knee replacement, don't worry, there'll be no blood or anything there. So we make an incision in the front of your knee. So that's the first thing I tell you will have. I open the knee, and see on the left, which moved away was your kneecap. And when we talk about knee replacement, people don't understand what we do. So it's a very, see what I'm doing here? I'm using a very precision blocks. And those of you who are, once again, mechanically oriented, I'm really fashioning the end of the bone so that it gets in such a position that I can put a metal resurfacing on. So see what I'm doing? I'm cutting the bone, but I'm only cutting small bits of it in a very precise manner. So I hope the public understands that knee replacement is not just chopping off the thigh and the leg, it's doing it in such a engineered principle of doing it. And see what's happened there is that the thigh bone is now prepared, and now I'm cutting the top part of the tibia bone, which was so rough, and now you agree, everyone, that it's become absolutely smooth on both sides. So Akram, it's smooth on the femur, it's smooth there.
It looks
and
clear,
the kneecap, look at the kneecap. I've not removed your kneecap. People always get confused, say, doctor, will you remove my kneecap? No, I just removed the part of the kneecap which was irregular. And what I'm putting on now is a metal bit on the femur bone and a metal bit on the tibia bone, and see that green bit there, Akram? The green bit for the audience is a plastic liner.
That's a plastic liner.
Yeah. So people have to understand that it's not metal moving on metal. In between, there's a polyethylene or a plastic liner. And then I finish by putting in these clips. I don't use drains anymore. So everybody coming to me, I would say I don't use drains. Drains were done to remove blood. And see, within 24 hours, so I'm telling you, within the first 4 hours, Akram, or 6 hours, or even earlier, we get the patient standing, we get the patient moving, and it's which we'll talk about rehab later, Akram, but the message from this video is you're standing and walking within 24 hours, but actually within 4 to 6 hours, if we can.
Walking with 4 to 6 hours.
If you're getting up, sitting on the side of the bed 4 to 6 hours, and by the end of the day, if I've done the case in the morning, I would want you to walk, or my patients to walking by the end of the day.
How satisfied are these knee operations? How good? Let me get a caller as well before you answer. Hello.
Hello, sorry brother, I phone call again.
Oh, thank you for calling again. Yeah.
I'm not understand. So you go, please. You go. Oh, you Bengali?
No, we don't speak Bengali. Now we had somebody translated for us. But if you could tell us simply what it is, and we will try to answer.
No, I tell you go my under breast you go pain. So I'm not understand what is a doctor.
So you have pain under your breast. It's
it look like stomach. Yeah, stomach in the belly.
Okay. Jai, we understand. I think it's as we explained, the pain, I think, is quite difficult for us to explain because you're an orthopedic surgeon, isn't it? And it looked like it's going to fall into more into a GP category, and GP has to, I think, look at. What do you think?
Ask her, I mean, is your pain in your left knee or the right knee or both knees?
No. I go in the middle and right and left.
But it's on the one knee only or both your knees?
No, both. And it go a long time. It go 5 months ago.
5 months ago, okay.
Yeah, 5 months ago, and now is there burning and pain, and back it go look like it go sharp pain. Look like someone, look like someone. It go knife. It go inside. Put it.
Yeah. It depends. Did you injure your knee? That's one of the questions I asked is, can you remember, did you twist or did you injure your knee, or it started by itself?
No, I go 5 months ago. My go cough. My tonsil. In tonsil. Doctor said it go tonsil, and I'm very scared. It go virus, and it go 5 months ago. My go too much. It go cough. Very cough, and after 1 month go, it go my pain start. Still it go pain.
Yeah.
So it go last week I'm going to hospital. My chest pain. So doctor said it go you tell your GP. It go endoscopy. Yeah, and yesterday it go very pain, and today just same. It go pain and burning.
Yeah.
Look like it go right side under breast, left side under breast, and in the middle. got coming in the middle place.
Yeah.
So the pain is not on your knee, is that right?
Pardon?
The pain you have, is it on your knees or hips, or is it no?
No, hips, yeah.
You don't have pain in your knees?
Yeah, pain.
Yeah, I think the ladies want to understand it's maybe the breast using is maybe in the, if she has a knee pain, if you don't have an injury, I think the next step would be to have x-rays done, Akram, if it's through the knee.
Yeah, good idea.
And that's what you'll need at the bare minimum. So you'll need x-rays of the knee, and then depending on that, then we can decide what you need.
Yeah.
But that's only for knee pain. If you're talking about your breast pain, that's something which I don't have any speciality to advise you on.
You know what you could do? If you could write to us on our email or on our Facebook link, I will try to get some answer for you and I'll reply you. Is that all right?
Yeah.
So we'll continue the program, and please talk to some of your family who understand a bit more English, or you could write in your words, and we will try to help you out with that. All right? Thank you very much for calling us. Okay, let's. We got a few more minutes left because we're going to make the program a bit shorter today for some of the days, and we have some other programs lining up. And do you refuse surgery for any conditions, and why?
Yeah, I mean, the first is I divide the patients into whether they truly need the surgery, like I've said, Akram. So when they are severe, with severe pain, they fit the criteria, they are very good patients, I know I'll give them a good result, I know they'll be happy patients, and it's very gratifying to do. So those patients are very clear, I'll do them. The patients who I will refuse, Akram, are very clearly those patients who I feel the pain is coming from a referred source, and that's very important therefore to examine their hips, I examine their backs.
They can still have pain on the knee, but the pain is not, the knee pain is not the primary source.
Yes, exactly.
So it's coming from somewhere else.
And that's very important, where once again, someone like us as a surgeon examining him is very important.
Okay, let me explain a little bit what is the referred pain. What we mean is you have pain in one side, but that you have problem in a different side, but the pain is referred in a different side. For example, you have a problem in your thigh, but you get the pain in your knee.
Very correct.
Is that right?
Yeah. So, or you have severe arthritis in the hip, for example, Akram.
For example, yeah.
And the patient actually comes and sits in front of the GP or in front of a doctor and says, I got pain in the knee. Of course, the patient's right. The patient got pain in the knee.
Pain in the knee, that's right, yeah.
But let's say the x-rays look normal, just suppose.
Yeah.
And we offer them a knee replacement, just suppose.
Yeah.
The patient's not going to be happy at all because we've not tackled the main issue. Which was the hip arthritis.
Right.
And the same thing, Akram, there are many patients who, as you know, many of the audience, you all have back pain.
Yeah, back pain, that's right.
So if someone has back pain and they have pain shooting down the leg, you know, many patients say, I got shooting pain down the leg.
Yeah.
Very often that shooting pain can be in the knee area, Akram.
In the knee area, yeah.
So therefore, once again, those are the patients I refuse and say, look, I'm sorry, I know you have pain in your knee, I know you have some arthritis, but I really feel your problem is not from the knee, it's from your back. I'm going to ask one of my spinal colleagues to see you. If they feel nothing can be done, and then I'm happy that you understand that the back pain and things won't be better, then we can sort your knee out. But I don't rush into it, and that's the second patient I refuse.
That's the second patient you refuse. Okay, let's get another caller on line with us. Hello.
Hello, assalamu alaikum.
Walaikum assalam.
I want to talk about myself.
Sure.
I'm taking medication regularly last 25 years. No complaint about anything against the NHS. I'm happy with my NHS, and I'd like to say something in your program. And sir, with medication need a meditation. With medication need a meditation. Vitamin D, vitamin C, vitamin A, vitamin B. एक मास আমি মক্কা থাকছি স্যার সারা দুনিয়ার চেয়ে সবচেয়ে সুন্দর হলো মক্কা সিটি সৌদি আরব 7 times beautiful of other part of world in this year the Makkah city in Saudi Arabia.
Yeah, sir. Thank you very much for your call. We understand your concerns. I think, unfortunately, this is not the topic we are talking, so we need to finish a little bit. We got a little bit left and our time is running out. Thank you very much for calling us anyway. So you could always write to us on our Facebook line or our email, ironhealthtalk@iron.com. We can always answer your questions there.
Sure.
Okay, let's go back when we refused the surgery.
So that was it. The other group, and this you have to be very clear, if you have medical conditions, and let's say I ask a patient, Akram, that you have breathing problem. Let's say a patient says, I get breathless, right? And then I ask them, what stops you from walking? Is it your knee pain which stops you, or is it your breathlessness? And if the patient says, no, it's my breathlessness, then you must understand that's one patient I will not offer a knee replacement, because their main issue is for mobility is not their knee pain, it's their chest problem.
Exactly.
And the other issue is if someone's had a recent heart attack,
yeah.
or a recent stroke, and by recent, I'm quite particular. I try to wait 1 full year after the heart attack, or the stroke, before I will contemplate doing a knee replacement, because the risk otherwise to life for having another issue is something which I will try to avoid. And these are the very difficult patients because they are suffering with pain. Imagine that man we saw.
Exactly, yeah.
And you have to try to keep him. So I don't refer back to the GP. I do my best to keep them in my clinic.
Yeah.
So that those who I'm refusing, I don't say, oh, go away, go back. I try to keep them in my clinic. I see them every few months, but they are my patients who I try to keep.
Excellent.
And that's what I try to do.
Okay, before we wrap up, let's talk a little bit of other surgeries you do. Let's play a picture and see. Do you do any keyhole surgery, stuff like that for knees?
So that's right.
And for what kind of conditions?
So remember, Akram, we saw the first X-ray, remember? Which we saw where the bones, and you showed a nice one where the gap was well preserved.
Exactly, yeah.
But those patients, most likely they are younger, and those patients would have had an injury maybe, and between the two bones, which we can't see on the X-rays, we have a cartilage which I tell patients is a shock absorber, and that shock absorber cartilage is called meniscus, but it's a shock absorber, and that can get torn, and that's picked up on an MRI scan. So Akram, MRI scan should be done for patients whose joints are well preserved, but they have pain, like many patients will have, and they have symptoms where the knee is locking or catching.
Okay.
Those are the ones I do a MRI scan, and if the MRI scan comes back as a tear of the cartilage, only then I will do what I was showing you, which is the keyhole surgery.
The keyhole surgery, okay.
With 3-4 cuts, and I remove the cartilage. And while we're there, Akram, just for the audience, there are many patients, because I do so many knee replacements every week, and that patients come and ask me, oh, can you do a knee replacement through a keyhole? Nobody in the world can do keyhole knee replacement surgery. This is different surgery. This is keyhole to just trim the torn cartilage.
Jai, thank you very much. I think we are running out of time. Even though it was a short program, I think we have managed to complete what we planned, and we have just given them a basic idea about this knee surgery. Jai, and you are a specialist and you've been doing this surgery. You must be doing a lot of knee surgeries, and you must be thousands of knee surgeries in the past. And of course, a lot of arthroscopies, the keyhole surgeries. And sharing your experience is really important, and we value your thoughts and ideas, and we are do you like to say anything else for the audience before we wrap off?
I just think that knee problems are significant for the population, and it's very common. I think everyone has to be sensible how you manage it, both from yourself. And I think, once again, the key is trying to be active, doing things like really building up muscles around the knee. So traditional exercise like cycling, weights or gym work is good, but under supervision of someone. And then see someone, and then be very sensible that every patient cannot have surgery, but we can. When we do offer surgery, it's a very successful outcome. If we do it for the right reasons, it's very successful.
And the rehabilitation is short as well. Can they be running around after the knee surgeries?
I would say when you say rehabilitation, when we are talking about knee replacement, which I do the bulk of, I tell every patient it takes 3 months out of your life. And that's a good you asked me that. It's not that they're lying in bed for 3 months, but The first 6 weeks are very painful, especially at night, because they work hard on the exercises we tell them to do, Akram, but then they get pain at night. And I tell them and their partners, please understand you'll have pain. And then the next 6 weeks after that, they become more active. So 3 months, I'm telling you, will be the public should understand it takes it out of you. So it's not a small operation. But at the end of that, knee replacements continue to improve gradually up to 1 year to 18 months.
1 year to 18 months.
And I follow them up. And that's one of the things that I follow them up and I make sure that any issues which they have, we address. And as a general rule, like I said, why I took orthopedics or why I'm passionate about it is that we can get good results.
Good results.
It's technologically challenging. We can help people.
Yeah.
But like I said, doing it for the right reason.
Amazing, Jai. Thank you very much. I think it was a great show and we had a great time and we have explained all of it. It's all about the knee surgery we talked about today. And if you haven't understood anything, you could always email us, you know, and unfortunately we're going to close our call lines now.
Sure.
We will post you could always say, look at our Facebook link or Twitter or Instagram, and please let us know if you have any more questions.
I'm very happy to do that.
By the time, Jai, thank you from our ION team, and thank you all for staying with us on ION's Health Talk with Dr. Akram. If you have any more further questions, please email us on healthtalk@iontv.co.uk or message us on Facebook or Twitter, and we will respond to you as soon as we can. But for now, goodbye and keep yourself safe. Thank you.